Let us see the various types of cellular adaptations. As I told previously, once the cells are disturbed from their normal homeostasis status, so they will undergo a very peculiar types of adaptations. So either it could be increase in their size or decrease in their size, increase in their number. So totally sometimes they may convert into one adult epithelium into the totally different type of adult epithelium. So let us see what are the different types of adaptations, how the cells will appear, what are the classical examples of the various types of adaptations. So the first and foremost and very common cellular adaptation is the atrophy, that is decrease in the cell size. So if it is a normal cell which is nucleus, so this is a normal size. In atrophy the size will be reduced. This is atrophy, decrease in the cell size. When the cell size is decreased, invariably the number of organelles are going to get reduced, and the organ which is get affected, the organ size is going to get reduced. Hypertrophy, increase in the cell size. This is hypertrophy. So cell size is going to get increased. Naturally, the number of organelles within the cell is going to get increased, and totally the organ that is going to get affected, it is going to increase in its size. So hyperplasia, that takes place only in few organelles, not in all the organelles. So that is increase in the cell number without increase in the cell size. That is hyperplasia. So the size of the cells remains same. So increase in the number. So that is hyperplasia. So these are the ones which are very common cellular adaptations. Rarely there can be things like metaplasia, where one adult epithelium is totally get converted into another adult epithelium. So this is change in the cell type is called as metaplasia. Then one more, a pre-neoplastic condition is so called as dysplasia, which is disordered arrangement of cells. So let us see the classical physiological and pathological examples of each one of these entities. Atrophy, remember, it is decrease in the size of cells. Physiological examples, like for example during development we have a thyroglossal duct that undergoes physiological atrophy by the age of around 14 years. So by the age of around 14 years, the thyroglossal duct, it will get totally removed from the body. It is by physiological atrophy. Uterus, after the parturition, after the delivery, again it revert back to almost normal size. It is because of the physiological atrophy. Pathological conditions where atrophy will take place. Example, decreased workload, disuse atrophy. For example, if there is a fracture of a limb and there is a plaster cast, and if the limb, particular affected limb is remain immovable condition, then the skeletal muscles will undergo a disuse atrophy. If there is loss of innervation to the skeletal muscle fibers, they will undergo denervation atrophy. That's again example of pathologic atrophy. Decreased blood supply. If there is no blood supply to the brain, so the brain will undergo the atrophy of the brain parenchyma will take place. That what happens in senile aging process. The cerebral arteries will undergo atherosclerotic narrowing. There is a decreased blood supply to the brain, and that's why the brain will undergo senile atrophy of a brain. Malnutrition. For example, in marasmus babies, the skeletal muscle fibers will undergo atrophy because of this. Vital nutrients are not supplied to the particular organelles. Loss of endocrine support, meaning endocrine glands will undergo atrophy. That's again example of pathological atrophy. Senile aging itself is an important process where the atrophy will take place. So atrophy is decrease in the cell size. Along with that, the cell organelles will come down. The number of organelles will come down. Hypertrophy occurs only at few organs in the body. So it's nothing but increase in the cell size by gain in the cellular substances. With the involvement of efficient and sufficient number of cells, the entire organ will become hypertrophic, and it could be because of the increased functional demand by the body or because of the specific endocrine stimulations, the organ will undergo hypertrophy. So this is the diagrammatical representation, normal, and this is hypertrophic cells. And not only the size but also the phenotype of individual cells can be altered in a process of the hypertrophy. With the increasing demand, the hypertrophy can reach a limit beyond which the degenerative changes will start taking place, and finally even the organ failure can occur. For example, the cardiac muscle fibers will undergo hypertrophy, and at a particular point that adaptation will go beyond limit, after which the degenerative changes will keeps taking place, and finally the heart failure can occur by congestive cardiac failure. So this is hypertrophy can be, it will extend up to certain limit, after which the degenerative changes will take place and the organ can die. Hyperplasia, most commonly it is due to the endocrine stimulation. It is increasing the number of indigenous cells in a particular organ or a tissue. So the number of cells are going to get increased. So most of the time it is a pathological hyperplasia. It typically results from the excessive endocrine stimulation. So endocrine organs like thyroid gland is going to get affected. So it results in enlargement of a thyroid gland, what we call it as goiter, is a classical example of hyperplasia. So in hyperplasia, the number of cells are going to get increased. Metaplasia is a very, very peculiar type of cellular adaptation where one adult epithelium is totally converted into another adult epithelium. So it is a reversible stage in which one adult cell type is replaced by another adult cell type. So here it is said to be a pre-neoplastic because normally metaplasia is a protective mechanism, but if this metaplasia continues to occur and if the injurious stimulus is not removed, metaplasia, there is a chance that it can undergo dysplastic change and it can even become a pre-neoplastic condition. And normal protective mechanisms with a metaplasia, they are going to get lost. For example, we have a respiratory pseudostratified ciliated respiratory epithelium in the this bronchial tree. So in a continuous smokers, chronic smokers, what will happen? This particular epithelium will undergo squamous metaplasia. So the normal functions, the respiratory mechanism, what we will have a protective mechanism, that is going to get lost. So metaplasia can make that loss of normal protective mechanisms are maybe lost, and persistent signals that results in metaplasia can predisposed to the development of the neoplasia. So in a metaplasia, the cellular adaptation in which the indigenous cells are replaced by the cells which are better suited to tolerate the specific abnormal environment. So example of squamous metaplasia is classically in the endocervix, where at the ectocervix and endocervical junction, the normal endocervical tall columnar epithelium is replaced by squamous cells because of the continuous irritation, like what happens in a patient with a prolapse. So this is an example of squamous metaplasia of the endocervix. Similarly, opposite to this, that takes place in the esophagus. Lower end of esophagus, normally it is lined by stratified squamous epithelium, but in a patient with a reflux esophagitis, this stratified squamous epithelium is replaced by simple columnar gastric type of epithelium. So that what happens in a patient with a GERD, gastroesophageal reflux disease. So that is called as Barrett's esophagitis or Barrett's esophagus. That's a classical example of a metaplasia. Here again it's an adaptive mechanism where lower end of esophagus is replaced by gastric type of epithelium. But remember, it may be a pre-neoplastic. It can predispose to the development of the adenocarcinoma in rare cases. Dysplasia is again a type of cellular adaptation where there is totally disordered arrangement of a cells. Very classical is the cervical dysplasia. We grade this cervical dysplasia into three things: mild dysplasia if the nucleus is little bit enlarged, moderate dysplasia if the nucleus is still enlarged, and severe dysplasia where the nucleus is so much irregular and it shows all the features of anaplasia. So it all depends on the nuclear enlargement, mild, moderate and severe. In severe dysplasia, it's almost like carcinoma in situ, where the nuclear borders are very much irregular, hyperchromatic nucleus you will see. So it's almost a pre-neoplastic condition. So that is the importance of cancer screening by pap smear examination in females. So cervical dysplasia is the classical example. Dysplasia is a precursor step towards the development of invasive malignancies. So one has to screen the cervical epithelium of the uterine cervix by routine pap smear examination, where mild, moderate dysplasia can be detected. If not, the severe dysplasia can develop, and where it can lead to the development of the invasive squamous cell carcinoma of the uterine cervix. So that is a type of adaptation that the cells will adapt themselves, that is dysplasia. So let us have two types of calcification, as such two types of pathological calcification. Examples: dystrophic and metastatic calcification. Dystrophic calcification is the one which will take place in areas of necrosis. Very commonly tubercular caseous necrosis. can undergo calcification. That is an example of dystrophic calcification. The atheromatous plaques can undergo calcification, is again classical example of dystrophic calcification. Damaged heart valve leaflets can undergo the calcification, like what happens in mitral valves in rheumatic heart disease. So they can be calcified and they show the dystrophic type of calcification. The tubercular lymph nodes, especially the cervical lymph nodes, can be totally converted into the calcified masses. So that's again example of dystrophic calcification. So remember the examples where dystrophic calcification will take place. So this calcified area, grossly if you see, it appears as white amorphous granular material, and if you cut that particular the dystrophic calcified area, you will feel that gritty sensation to your cutting knife. And microscopically, if you examine that particular section, you will see it as amorphous basophilic. It will take basophilic color and it will show crumpled appearance. So by seeing it itself, you can make out that yes, it's a calcified area. So that indicates it's a area of calcification. Metastatic calcification takes place where calcium deposition in a normal tissues as a consequence of the hypercalcemia. So serum calcium level estimation is the most important point to call it as metastatic calcification. It may be due to increased parathyroid hormone secretion, or maybe because of the bone destruction, that what happens in a patient with secondaries deposition in the bones. Vitamin D disorders, like either by intoxication of the vitamin D or in cases of sarcoidosis. Renal failure patients also can show metastatic type of calcification. So remember the examples where dystrophic calcification and metastatic calcification takes place. Metastatic calcification, it's mainly the hypercalcemia levels, whereas dystrophic calcification mainly the tubercular lymphadenitis and damaged heart valves and the area of necrosis. So that's the two types of calcifications, pathologic type of calcifications. So let us see the details of necrosis as such in the next topic.